All right. We're going to go ahead and get started. First, I want to thank everybody for joining us today. This is a really important topic. First, let me introduce myself. My name is Yenvy Truong. I'm the host of this webinar. I started this webinar series. It's going to be every 2 weeks. This webinar is going to be a combination of very focused information and education for women. And it's not just on health, but it could be on technology, it could be on business development, it could be on growth, personal growth, whatever it is that's really important for us to know as women. Today's topic on perimenopause and menopause, and then we'll go into certain things that we don't really talk about, which is perimenopause and menopause as well. I think things are starting to show itself for us to have this conversation, but it hasn't been around. And the only reason why we even think about it is because the symptoms get so bad, right? And that's in with the case with me, as you know, I'm in my early 40s, and the thought of perimenopause didn't even come to mind until I had the very obvious symptoms that women talk about sometimes is the hot flashes. And then I was like, why am I standing here and all of a sudden getting hot? I'm in a room where everybody's freezing, but I'm like sweating now. And so that would start, the process of me asking myself, well, what are these symptoms? What's happening? And so there were things that I just didn't know. I've been living with these symptoms for God knows how long, probably 3, 4, 5 years, just thinking that it was just, part of PMS and whatnot, right? But then it ended up being these fluctuation in hormones associated more so with perimenopause. And luckily, I have a good friend named Dr. Michelle Cox. And when I was going through this process of discovery and really identifying, asking questions, I sat down with Dr. Cox and we started going through my symptoms, and we realized, yes, you have it. You're in full blown. And then even further, I asked my mother, when did you have menopause? I knew it was young when she was younger, but then she said 43. I'm 44. So I thought to myself, why didn't I have any? When I go to my doctors, they've never asked me the question of when did your mother have menopause or when did the women in your family have menopause? Because that gives you a really deeper understanding of where you are in fertility, where you are in your life cycle, where you are in your career, because all these symptoms and fluctuation actually impacts the way your lifestyle is. And I didn't realize how impactful it was until some of my symptoms were so heavy. And so I thought it was extremely important that the women in my life, my friends, my family, my associates, every woman know that and have the information they need to make the right decision, to ask the right question, and do the discovery and research around this topic. And so I'm really excited to have this conversation today. And I think my background in science and research and entrepreneurship and just always asking questions and trying to think of how to find solutions for problems allow me to sit down with Dr. Cox, and we've built this webinar so that we can ask questions that are really heavily focused, that you're going to walk away going, wow, I had no idea. I'm so more educated now, and I know how to have questions and answers with my doctors about this. Okay. And so, before we get started, I do have to read a disclaimer since we're talking about healthcare and we're giving you information. The disclaimer is the information provided in this webinar is for general informational purposes only and should not be considered as medical advice, diagnosis, or treatment. While we have a physician presenting and addressing questions, this webinar does not establish a doctor-patient relationship. We encourage you to consult with your own healthcare provider or a qualified medical professional for advice tailored to your specific health needs or conditions. The views and opinions expressed by the physician are their own and may not reflect the views of all medical professionals or this platform. By participating in this webinar, you acknowledge that neither the physician, myself, nor any associated entities shall be held liable for any outcomes related to the use or interpretation of the information shared here. Thank you very much for understanding, and we look forward to a great session. And before we get started, I'm just going to give you a little breakdown of how this session is going to work. Michelle's going to go ahead and present some information so that you're more aware of the education around perimenopause and menopause and the health and the symptoms around it. It's about 15 to 20 minutes. And then she and I are going to have a discussion. It's more of like a panel discussion on some deep questions that I think that I've been, asked myself and that I've asked my physicians and I think that everybody should be aware of. And then from there, after that discussion, we'll open it up to a Q&A by the audience. So if I didn't answer your question, or Michelle or Dr. Cox did not go over some of those questions, please drop your questions in the Q&A box, not in the comment section, but the Q&A box, the question and answer box. That's where I'm keeping an eye out for those questions. So at the end, I'll be able to answer your questions at the end. And then at the end, we'll have about 2 to 3 minutes of just a closing statement of, how you can get in touch with Dr. Cox. And if you need the support from there, we'll be sharing the link and all the information around that at the end. Okay, so I'll go ahead and hand it over to Dr. Cox so that she can, kick it off.
Thanks, Yenvy. I'm so excited. All right. I mean, your disclaimer was much better than my disclaimer. I'm glad you covered it all. But let me know when you can see my screen, please. You can see it now? Okay, yeah. Great. So here's my little disclaimer, right? That this conversation today is for educational purposes only, and it's not intended to replace personalized medical advice, diagnosis, or treatment. Please consult with your own healthcare provider to discuss your individual concerns, because it really should be like that, individually addressed, to determine the best action for your needs. While I'm going to share my personal experiences and clinical knowledge, every person's journey through perimenopause and menopause is unique. But my goal today is to empower you with information to advocate for your own health and have more confidence around this topic. I'll share some personal thoughts, and as Yen mentioned, I am a little different and may have some different perspectives than maybe conventional medicine. I come from a longevity-focused background and a regenerative, holistic, integrative medicine perspective. So some of the things that I may talk about today may not be things that your typical healthcare provider will discuss with you. However, I think it's important to ask these questions if it interests you, so that the shift starts coming from us consumers too within healthcare. All right, with that said, I'll get started. Okay, here we go. So when Yenvy asked me to do this talk, I was like elated to do it, because I've been having a lot of side conversations with a lot of women. I'm also in my 40s. And, this is just a topic of passion for me. And so I want to share a little bit about my story before I dive into this, because I believe it mirrors one that so many challenges that other women are facing right now. And even though as a physician, I was trained to diagnose and treat countless of conditions, when my own health began to shift in my late 30s, I found myself lost in a maze of symptoms. Now, it took me years, guys, years to figure out that I was in perimenopause. That term, I'm going to be honest, I went through, in the early 10s, 2008 to 2012, I was in med school. The word perimenopause didn't even really come up in med school. So it wasn't even taught to me back then. And we only learned about premenopause, menopause as a time in space, and then postmenopause. And I have this medical condition that causes increased pressures in my brain, which causes compression on something called my pituitary gland. And while the medical literature doesn't really discuss the impact on hormones, I knew something was profoundly off. As young, I started having all these symptoms. And then I took something called an epigenetic test, and I saw that my hormones, even though I was aging slower than every chronological year, meaning every year I spend around the sun, I was aging slower, my hormones were in their 50s. And I was like, oh my gosh, okay, that confirmed it for me. Like, that's enough. And it started I started to see like, okay, this is why I was having like weight gain around my stomach. I was getting injured easier during my workouts. And I was like, what the heck is going on? My joints, I had this like brain fog that I was like literally trying to find words, and my mood swings were like outrageous. So it was a really, really humbling realization that even as a physician, I had to be my own advocate and piece these solutions together that weren't immediately obvious and available. And gratefully now, with like the longevity support, having this information, hormones, I will tell you that I am on hormone therapy. I began to see real transformation. I've lost like over 40 pounds and narrowed my midsection again, feeling a lot better, thinking clearer. My joints are doing a lot better. So even though my journey's not quite over, I have a stent procedure, in March for my brain here. I've gained so much insight, and I hope to share that with you today. This is why this conversation is so important, and really hope to impart some information about how to advocate for yourself and seek answers and embrace this as a phase of transition that is yummy and wonderful. Okay, everybody's not dreading puberty, reproductive years, and menopause should be no different in being postmenopausal. All right. So coming into this, I really like how, believe it or not, it's like, why do women feel unsupported during this like really natural transition? And I was looking here at this wonderful study that was put together by Avon, believe it or not. And 44% of women were unaware of perimenopause, and 46% did not expect perimenopause to start when it did. So, like, everybody knows the word menopause, and they know that their period, just stopped, and they know about hot flashes. But beyond that, is that really enough? And what do we know? And so, why is this? Because symptoms are kind of minimized or attributed to aging. And it's just like, oh, you're getting older, like, that's just part of life. Or they're taboo topics like vaginal dryness. Hey, yeah, and when was the last time you and I talked about our vaginal dryness together? I mean, hello. I consider Yenvy one of my close friends. So it's like, like we don't talk about this, like, hey, sex hurts or this or that, together. Lack of education and misinformation. There's so much information right now being put out there from non-expert sources, leading to confusion about what treatments are, and really perpetuating the lack of shared knowledge across families. So just generational disconnect, like Yenvy turned to her mom, I turned to my mom, but it's like there really wasn't a conversation like, hey, your period's coming, hey, menopause is coming, kind of thing. And that's important because, as Yen mentioned, there's some women, even in a study of over 700 women across the globe, that were really upset when with their mother, when they found out that she had menopause at 37. So that impacted her fertility window. And she would have started her birthing plan like way earlier had she known that information. So that's really big. There's a healthcare system gap that I kind of mentioned before that we're not really talking about that. I'm going to get into some statistics and studies here in a minute. And then there's a negative portrayal, and even more important to me, a lack of a positive narrative around menopause and being postmenopausal and how fun that can be. So like, I loved this right here, that a quarter of women globally said that since menopause, they had the best sex of their life. And they felt liberated, excited, and over 70% were like, I am so glad to be done with Aunt Flo, right? To be done with it. So let's hop into some reasons why. Let's pay attention to this just a little bit more. So these might be some things that you could be experiencing. Women can gain an average of 10 to 15 pounds during perimenopause, even with no change in diet activity. I want to say this is like probably like the number one thing, Michelle. I'm working out, I'm eating the same, I'm actually sleeping, I'm like paying attention, I'm meditating. What the heck? Why am I gaining this weight? What is happening here? And it's 85% of women experience changes in their metabolism or fat distribution after menopause. Another important thing is, without intervention, women can lose up to 20% of their bone density within the first decade after menopause, meaning once you've hit postmenopause, and we'll go through that. And then the thing that I found really interesting that we really need more studies on and start looking at, how does this affect our cognition or the way that we think long term? How does it lead to dementia potentially? Post-menopause, the risk of Alzheimer's increases up to 75%, up to 75% due to hormonal shifts. All right. So 80% of women experience psychological, physical symptoms. Vasomotor symptoms, those are going to be like your hot flashes, night sweats. They're associated with increased risk of depression. Menopause-related sleep disturbance will influence your eating behavior, the timing, your metabolism, your immune system, and your abdominal fat through other systems that it impacts. It's also associated with increased risk of sleep apnea. A lot of women don't even think about that. They're like, what? Sleep apnea? I'm like, yes, get it tested. So each year that you're in that transition, you have a 4% increase, and that's stacking over time. And those vasomotor symptoms that we talked about, once you start to experience the hot flashes and night sweats and, things like that, this is an indicator of your cardiovascular disease risk going up. And like, it should be a signal to your provider, hey, we need to start paying attention to your cardiovascular health. Okay, so there's a lot of things here. This gets a little sciencey. Instability impairs endothelial function, increases risk of hypertension, osteoporotic fracture, cardiovascular disease, depression, and cognitive impairment. So what it's saying is like, get some help. And maybe the best kind of analogy I have is sometimes when women or young girls, they need assistance with their periods, we go on birth control. There's lots of options out there, right? So it's not like you have to suffer through something, even though it's natural and normal. It's like getting an epidural during, birth, right? Birth is a natural process, but there are cool things in 2025 that we can do. So unfortunately, about a third of GYNs don't even screen for perimenopause, women for depression even. And then we're going to get into menopause occurs normally between age 45 to 56, with the min age being around 51. So if you get the recording, here are all my references there for those articles that are cited. And so, hey, we know what's going on the outside here, right? Like our body is changing, but like what's happening here and this shift? And Yen specifically asked me, she's like, put that chart in there because I like it. So it's this premenopause. So we'll call that your reproductive years, where and this is where it's challenging and where I believe it's like really nuanced, because many women deal with something called polycystic ovarian syndrome, or like Yan mentioned, PMS, and there's thyroid issues that can impact just your regular cycle. So like in a cycle that isn't affected by a different condition, these are supposed to be regular cycles with predictable patterns, and good ovarian responsiveness. But then around that time, we've got this perimenopause, and you see this, like, this is talking about estrogen right here, and you get these fluctuations, and basically the body's like, yo, we need more, and the pituitary is like sending these hormones out and like saying, hey, make more, and nobody's paying attention. Everything's going up and down, and it becomes like this real big roller coasters. And because we don't ovulate 1 month, and our progesterone drops, and now we have estrogen dominance, I'll go over that in just a little bit, but you have like heavier periods with that, and breast tenderness, and you start having a lot of physical changes here. And then menopause is like technically literally a day. It's 12 months after your last period. Okay. And then you're post-menopausal, and it's showing here that the average age is around 51. So this is the new normal. So now we move from an estradiol to an estrone, which is it's a weaker form of estrogen, coming the main type of hormone that becomes dominant, and it's made in your fat tissues. And progesterone is pretty much gone as ovulation has ceased. You still have some testosterone because you have some present from your adrenal glands, but the idea is that this is where, bone density, heart health, cognition issues start to become an issue in an estrogen deficient state. Okay. So here are some symptoms of high estrogen. Why do I put that in there? Because it can happen with things like polycystic ovarian syndrome. It can happen while you're in this perimenopausal phase. So where your progesterone is too low. So sometimes it's not just getting estrogen is the answer. It's saying, oh, maybe you just need a little progesterone support right now, or pregnenolone, which is like kind of upstream to that. So cyclic breast tenderness, fullness, short menstrual cycles, heavy periods. We're going to have those mood swings, migraines, headaches, irregular vaginal bleeding, uterine fibroids, you're retaining more water. And then low estrogen, when it's consistently, kind of getting, where did that picture go? Kind of towards here, where these estrogen levels are now, yes, you're still getting little surge. So this would we call like late perimenopause, early menopause. So late perimenopausal symptoms. Now we're looking at that brain fog. That brain fog actually starts a lot earlier, ladies, like a lot earlier. And then depression or anxiety, sleep disturbance becomes more notable, vaginal dryness, lack of libido, joint pain, bone loss. So osteopenia, osteoporosis, weight gain, and then of course, what we all know about hot flashes and our night sweats. Doing okay on time, Yenvy? Okay, good. All right, so I wanted to equip you with this tool. So this is a validated tool. I am going to say that I have met people that go in and they're like, I'm in perimenopause or menopause. And the doctor's like, okay, here's your hormones. And they never looked at their symptoms. So ladies, really, you should be getting some blood work. You really should be getting some blood work to look at multiple systems, because this could be impacting multiple things, and they're all interconnected. They really are. And then you can Google this right now, a menopause rating scale. This is a validated questionnaire to look at your quality of life with your symptoms. So the big ones I like to highlight, yeah, everybody knows hot flashes. I know this is kind of hard to see. Can I zoom in maybe? I don't know, without messing it up, but I'll read it to you. Joint and muscular discomfort, dryness of the vagina, bladder problems, sexual problems, physical and mental exhaustion. So general decrease in performance, impaired memory. That's the big one. It's like, what the heck did I do with my keys? Or what was I doing? And I have to, concentrate all over again. Forgetfulness, irritability, depressive mood, sleep problems. That's really, really big. And heart discomfort. And Yen and I were talking, she's like, what do you mean by that? I mean, like palpitations, like starting to have issues in the way your heart is working now, and it's a muscle. Okay. And hormones very much impact your muscle mass and your muscles, to include your heart. So this is how it's like leading to cardiovascular disease risks. There's muscle in your arteries too. So if you can imagine, all of a sudden your cardiovascular system is reducing its function, that's going to cause a lot of problems downstream as well. So what are some practical tips? There's a lot on this slide. So I'm going to try to be kind of simple, and then I'm going to highlight maybe from a more longevity perspective on the next slide. But the big things I would say are lifestyle changes. So trash in, trash out. I know that sounds like so basic, but not eating processed foods is really big. So reducing that, increasing your dietary fiber from different plants, different colors. That's important. And your protein to maintain muscle mass and even build muscle mass, even postmenopausally. Anti-inflammatory foods. There's different herbs and supplements that can help, and beyond the scope of this talk right now, but that you can talk to your provider about or hit me up, and those can help alleviate a lot of symptoms. You might have heard of things like black cohosh and turmeric and things like that. Exercising is so important. Remember, we got to keep that cardiovascular health up. All right. And weight-bearing exercises to protect our bone mineral density. Stress management. So techniques like mindfulness. A really, really easy one is just like, breathing in for 4 and out for 8. And repeating that cycle several times. So that's super, super simple. And then like tapping, that's a physical one you can do. So there's a lot of options there. treatment options to discuss with your doctor are hormone therapy. There's different types of hormone therapy. Maybe we'll get into that in the Q&A section. This is going to be very effective for those vasomotor symptoms, but really it does start helping with cardiovascular, improving risk, reducing risk for cardiovascular disease, reducing risk of, believe it or not, cancer too, the younger you start. So it's generally safe under 60. You want to start that as soon as you start having symptoms, has better outcomes. Okay. Or within 10 years of menopause onset. Now, there are exceptions to that. I have started women even later than that, just depending on their symptoms. Again, this is where an individualized approach and looking at their risk factors and genetics are all very important. Non-hormonal therapies, so SSRIs, SNRIs for mood swings or hot flashes, gabapentin, Lyrica, other emerging therapies, or let's say you can't take it orally for some reason, and there's lots of, not a lot, but there's a list of contraindications. There's other things like vaginal, like putting it vaginally, or DHEA, which is upstream for genitourinary symptoms. What does that mean? Like you feel like I got to pee all the time, or you're having a little bladder leakage, or because things start to loosen up down there instead of staying nice and tight. And then there's things like Veoza you might have heard of from TV ads that are looking at certain receptors to help with hot flash reduction, acupuncture, and cognitive behavioral therapy. And there's also, I believe it's MCT too. So different types of therapy to help with mood and sleep issues. Sleep hygiene is big. From a longevity perspective, my partner and I, we really start looking at sunlight and your circadian training. That's really, really big. We're going to really look at optimizing your lifestyle and your well-being, because at that point, once you kind of bring you from an optimal point, then we'll add other things. And there's things too, that you might need a little assistance on before then too, but it's really going to be about, okay, if Yen is pedal to the metal all the time, let's really start looking at that stress management. And what are some tools like that breathing I showed you today, or conversations like, I have folks that, God bless them, we love our husbands, but like that they're having relational issues, and that's actually causing a lot of stress for them, too. So it's really having that kind of holistic approach and looking at sleep and optimizing your sleep, because it's kind of a chicken and egg issue, right? It's because if you're not sleeping well, all these other systems downstream start to degrade faster, right? So optimal sleep for us is really big. Thyroid function, having hormone support as needed from that point, because there's a lot of supplements and things, and you may find you get a few more good years in that pre or that early perimenopausal state, and then community. I put that in a huge underline, because just being able to talk about it with your friends, with your family, with your sisters, with your parents, I mean, that's so cathartic in and of itself. It's like, yeah, I had this major mood swing yesterday, and we can all laugh about it. It starts to normalize this transition. Just like, I hate to say it, my poor son Phoenix, like we laugh about his voice transition happening, during puberty and things like that. So, at Life Bloom, that's my practice. There's my beautiful partner, Dr. Jadan Myrna. We really are looking about thriving. It's all interconnected. And I hope that this talk, and we're going to do a Q&A here, is like equipping you to be able to have these conversations with your healthcare provider. And I really love this quote by Maya Angelou: do the best you can until you know better. And then when you know better, do better. So that's what Yen and I are praying to do today for you all. And thanks for having me on, Yen.
Thank you so much. That was wonderful. And, that was just kind of just touching the top of the iceberg, right? Just like scratching at the top, just because there's so much more that I think there's a lot of questions that everybody's asking and thinking, and like, what do I do next? And what kind of doctors do I see? Like, what do I say to my doctors exactly? And so just from my experience, sitting down with Dr. Cox and having a discussion around this, what that allowed me to do was do more research and then dig into some books, and then I was equipped enough to say, I want to go into hormone therapy. And I started HRT about a week ago. And I feel immediately within 24 hours, and it was a small dosage, but immediately I could start feeling different, which is insane, right? I'm not advocating it for yes or no. I'm just telling you my experience on it, right? And again, everybody has to do their own research and feel it for themselves, but there's different types of HRT and different types of therapy, right? There's BHRT, bioidentical hormone replacement therapy. There's HRT, hormone replacement therapy. And then there's this new term called MRT, menopause replacement therapy, right? And so I think that's a question that we should just touch on because everyone says, well, I've been hearing about this, but I don't know if it's right. And I heard that there's this whole thing about cancer with hormone therapy and everything. So I'm kind of scared. And then I've been in menopause, but I don't feel optimal either. And so can I start menopause? I mean, can I start hormone therapy even though I've been off, I've had my menopause maybe 4, 5, 10 years ago. And so I guess the first question to ask is, could we share on what the difference in therapies are? And then how do they decide what's right and what's wrong for them to start off with?
Yeah, yeah. So I want to caveat this with like, that list of symptoms that I showed on that. I can stop sharing screen if that's helpful.
Yeah, let's do that. Mhm.
Click.
Okay, great.
That list of symptoms that I went through, I mean, there could be a lot of other processes happening that are impacting that. And like it really is all interconnected. So let's say you've ruled out a lot of that. You've ruled out a lot, and it's like, it's got to be perimenopause. But and looking at your genetics, meaning like when your mother hit it and like what's happening in your life and things like that, then I would okay, so here's two rules. One, check your labs beforehand. There's something called FSH, LH, you know, your hormones itself. You want to make sure that you have had a regular pap smear, that you don't have endometrial issues or reasons for abnormal bleeding. Like there's a history that needs to be asked before we're possibly going to give. There are cancers out there that love hormones, okay? There are cancers, okay? So we do need to check that and make sure that we're not starting everybody on hormone therapy, which, ladies, I'm going to say there's hormone clinics popping up all over the place. Please don't do that. Please, please. Like have somebody with a more like a primary care provider, your GYN, who is going to be looking at the implications of things like across the board, okay? Because these do come, it needs to be an informed consent. So we can say, okay, you mentioned bioidentical hormone replacement therapy. I personally leave the R out. I like hormone therapy because like it's just there. But bioidentical is going to mimic what your body already makes. Okay. And so the theory, well, not theory, but there's some studies showing that, like, for an example, Premarin and estrogen's taken, from horse urine versus estradiol is usually, which is the E2, it's a type of estrogen that your body makes. There's 3 different estrogens. It's usually taken from a plant-based source to create that. They're going to have different downstream effects. So they're both going to make you feel great. I personally say, like, what's accessible to you? Are you dealing with gut health issues? Do you already have liver detoxification issues? Because all of these hormones are processed by your liver. And this is where I even say conventional medicine may not address it in the way that I would, because these things get converted into metabolites that can be harmful, depending on your body. So this is where, like, even your genetic testing can be important, but like not to overwhelm people. Bioidentical, usually a lower side effect profile than synthetics. And you want to be aware of how your body is doing overall. Like, do you, for an example, hold on to heavy metals more, which some people do? Do you already have like gallbladder issues or fatty liver disease? Because this is being processed by your liver. Do you see what I'm saying? So like have more of a conversation around that with your providers, because if they're not even thinking about that, then good grief, like what happens when you like really overload it? Because here's the other thing I would see all the time. People get started on hormones at one of these hormone clinics. It was great. It was great for 3 to 5 years. And then they're like, I'm exhausted again. I'm having all these issues. And it's their inflammation, right? That you and I talked about, Yen. Like it's their body that's inflamed, and this is not helping.
Mhm.
Okay, so I think I answered that. Cancer risk, that actually reduces cancer risk across the board, hormone replacement therapy, but there are certain cancers, like I said, that are susceptible to hormones. And so being screened for that is very important.
Mhm.
Did I miss? There was like
Yeah,
another
the
question.
for a person that already went through menopause, for
Oh,
example.
already went through menopause. So like I
Yeah.
said, for the most part, up to 10 years, it's pretty much standard now that everybody's like, it's cool. Yeah, 10 years. But on an individual case by case basis, your GYNs, your doctors, your primary care doctors, longevity doctors, like we can look at things and say, okay, let's pro con this, take into effect her family history, her genetics right now. Um, and we can see if maybe a low dose, for an example, of vaginal estrogen cream may
Mhm.
be a great place to start, or something that I do, which not a lot of providers do, is, I'm going to train the circadian rhythm. Might start with something called pregnenolone or DHEA, which is a little bit more upstream, and start to work on some other supplements, getting their diet healthier, getting outside in the sunlight and eating. There's a lot more to do before we say, hey, get hormones.
Right, right.
Does that make
Yeah,
sense?
yes. And I, just to share some information on when I went to my doctor, granted, I'm a scientist, I'm a researcher, I do all my own stuff in essence before I request for some type of medication. And most of the time I try not to take any medication, right? I try to keep it on supplements and stay as natural as possible. But this was the one case where I said the symptoms are so bad that I do need something, right? And you even gave me a list of all the supplements to take that could help me with my symptoms. Sleeping was one of the major ones. But I'll tell you, when I went, I read everything. I read books. I watched the master class on perimenopause and menopause, etc. And so when I went to my doctor, I spent less than 3 minutes, about 3 minutes with my doctor. And I walked in and I said, I'm in perimenopause, and I want hormone therapy. And he goes, "Oh, okay." He goes, when he goes, "When did your mom have menopause?" I go, 43. So I already knew because I had been doing the research, right? Otherwise, how many women would sit there and go, "Oh, I don't know. I need to ask my mother," right? Or I need to go ask and find out. And then he goes, "Well, maybe we'll do some blood work." And I go, "Do we need to?" And he goes, "If you want to." And I go, "Well, what's in the panel?" And he goes, "Thyroid, a thyroid panel, and then some hormones." I go, "Thyroid? Okay, let's do the blood work." So basically, I told my doctor what I wanted because I did this research. But the problem is that I think this is one is these are the hormone clinics that you're saying, right? And then this is the traditional, right, type of medicine. Walk in
Yeah,
and they're going to fit you in a box and then they move. And if you come in and you're already educated, then you feel more confident with what you're requesting instead of waiting for the doctor to tell you what it is. And I think,
yeah,
like you told me when we first started having this discussion, was that it was so much more symptom based than actual lab testing itself.
yeah.
You
That's
saw
right.
my lab test, because I asked for it, right? And so there were some things I, would have suggested this, of course, but at the same rate, what if my lab test came back normal? But my symptoms were there. Like how should the listeners or the audience really think about that? Like my lab test is great. I'm full for fertile and I can have babies according to my doctors, but I feel all the symptoms that you've described. How should we think about that? And
Yeah,
I
I
think
think it's
for the
important.
graph. Sorry,
What?
Michelle, I think this is the graph that you showed, that jaggedness,
Yeah, yeah,
is so important because of that
yeah.
question, right?
Yeah. And it's also like once you start HRT or hormone therapy, I'm just going to say, like, do you evaluate your labs beforehand? What are they doing throughout that testing? And then how do you monitor my progress? Right. So it's like I put you on, I feel better. Great. I mean, like, really, though. So that's why I gave that questionnaire because it's important for you to kind of look at it over time. Like, oh, am I actually improving? Is this actually helping? Was this actually the issue? Or was it maybe rheumatoid arthritis? Is it some other autoimmune disease? Or really, is it early stages of cognitive impairment from dementia? Because that comes from my family. Or is it some psychosocial emotional factor that's happening in my home affecting my libido? You know what I mean? So it's like, I think how they monitor it is very important, and how they look at balancing things. It's not a one size fits all. It really isn't. So, and then I think another important question is how much experience do you have treating this? Because gratefully, most women, we do. I mean, I know there's an access to care issue. I really do. And I acknowledge that. It's just, it's like, how much experience does someone have working in this space? You want to see an expert. You don't want to necessarily see somebody who is like, oh, I guess I can put you on some hormones or, I guess I can do that for you. Yeah, sure. But it's like, oh, okay, never mind. I'm gonna like find someone else who's like, who's been doing this a while and can even talk about the anecdotal stuff because the evidence is just coming out. Like we're just starting to collect this data and the research.
And so, I'm sure there's an audience full of women that want to go talk to their doctors, right? Have appointments with their doctors to talk about
Yeah,
this because of the
yeah,
symptoms they're having and the way they're feeling, and they just want to feel better. So, are there questions that you suggest? One is to kind of vet it, whether it be vetting or whether it be just identifying whether that physician um, is going to be a partner in this. Let's just put it that,
yeah.
you know.
Yeah, I think that's big. I think keeping a symptom log is very important
Symptom
too.
log.
It's like a symptom log is very, very important because you could be like, you know what, like this many times a week, I'm having, and there's apps too for this too, like I'm having a 7-day fluctuation in my menses. Well, that's going to change. I'm noticing more fat around my stomach. These are all signs, like these kind of physical signs that maybe it is perimenopause or estrogen or dominance or, something happening that it's related to that. Um, but then, the other questions are kind of like what we mentioned already. It's like, well, how do you evaluate me? If like they don't even ask you, like, no offense, Yan, to your doc, but like they didn't give you any kind of a quality of life questionnaire to look at that, try again. You know what I'm saying? Like something, if you go into see a psychiatrist, psychologist, they'll do like this PHQ-9 for depression or a GAD-7 score. Like these are validated things to look at our quality of life when it comes to perimenopause, menopause.
And it's really interesting because the physicians I've gone to, I've always told them what to do.
I know. That's you, Yenvy.
I
I'm
was
just
like,
kidding.
can you give me this? I need this blood panel and I want this. And they're like, okay. And so maybe it's because when I logically tell them my symptoms or I just kind of tell them and they're like, yeah, he checks all the boxes, sounds right. Okay, yeah, you sound like you did your research, right? And so it's
Yeah,
really important, that we have one is we do the work and research on our by ourselves as well so that we're confident in it and then listening to webinars like this and whatever's available for you to make that sound decision. Like you said, it's there are risks associated to some of these um uh therapies and other, supplements and everything. Like for example, with hormone therapy, my doctor asked me if I wanted the pill. And I go, well, I read that you shouldn't take the pill because it has to be processed through your liver. And then I read how the patch is better. And so I was like, okay, I'll take the patch because it's not going directly into my liver from the pill. And so there were things like that I was like, I'll take the patch, right? And it's more convenient in that sense. But the questions, we've what are the questions like associated with like really qualifying that doctor, like um how long have you been doing this for? Like are
I
you
mean, women have an incredible intuition, and I really say lay into that. And if
yeah.
you're like, whoa, this person really listens. This person is like looking just beyond my age or my hormones, and like they're looking a little bit deeper here. Like, and you feel when you get that yes in your body, I'm going to say that's first and foremost, because I always say lean into your intuition. And if you can give them, you can ask, tell me about some of the women you've been treating already. What are they on? What are some challenges that they have faced?
Yeah.
And if they can't really have a conversation like, why did they come to you first? Was it that brain fog? Was it the fatigue? Was it the hot flashes? What's your most common protocol that you do to
Mhm.
treat people? And this is where um it matters, because some people are like, look, I'm going to tell you right now, I'm not a fan of pellets. I'm not.
You-
So like, if they're trying to put pellets in you and tell you this, then I walk away. Like that's a red flag to me. Just walk away. But I mean, there's little cases with that, but like, are they asking you like about your family history, right? Like, do you have breast cancer in your family, endometrial cancer, or, do you have clotting issues? Are you a smoker? These are like super simple questions. What does their informed consent look like for hormones? Yenvy, did you sign an informed consent for your hormones? What the F?
No.
Absolutely not. Like, hello. So like maybe if you don't sign it, okay, but we go over it together, right?
Yes.
So, and you can tell if somebody's just looking at you and being like, yeah, okay, up and down, yeah, I've got 5 minutes, what do you want, da 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 da, right? Be like, you know what, I'm good, I'm gonna find someone else.
And it's having that partner. One of the reasons I went to my doctor is because it's covered by insurance as well. Not a lot of insurance varies for the person,
Yeah,
but some
yeah,
of it like BHRT or BHT is not necessarily always covered.
that's true.
It is an out-of-pocket thing. And so for women, finding that access for that, but also knowing that that's what you want, right? Because you've done the research and around
And
it.
I always say you can take like estradiol, you can take that orally and you can pick it up at CVS. You can
Mm.
take progesterone and pick it up at CVS. I do.
Oh,
Like my
okay.
stuff is prescribed by my physician, by
Mm,
my GYN at the VA,
mm,
So these are things that you can access through standard healthcare.
mm.
It's just having someone, that's sitting across from you who's really partnering with you,
Right. Hmm.
So it's not, you don't have to go to all my stuff for the most part, other than my supplements, right, are through a pharmacy.
Great. So I'm going to go into some of the audience Q&A. Okay,
Okay.
there's Q&A. And so what blood test should I talk to my doctor about?
Ooh, okay. So that's challenging. Can I know their name? I love addressing names. Who's asking? Christy? All
Yeah.
right. So Christy, that's really challenging, right? So to know, what's going on in your life, what are your symptoms? Is it more, for an example, is it more mood related? Is it more about hot flashes? Is it more about sexual dysfunction? Is it more about fatigue? I mean, because fatigue could be anemia. It can be your thyroid, it could be like your cortisol levels being in a chronic state of stress. So that's really challenging. It's a great question. It's a great question, but it's like you need a physician or a provider that's looking at the full scope for you to really start digging in. There's something called a differential diagnosis, right? A differential diagnosis means I'm looking at other things that it can be. And I'm not just pegging you into this. Otherwise, we miss things.
Right.
So yeah, it should be tailored.
Okay. And then if I have a progesterone IUD, how would that mask symptoms? Will it impact transition into menopause and will it impact lab work?
It can, depending on it can mask some symptoms, to the short answer of that, and impact your transition, in terms of not having the progesterone deficiency or the estrogen dominance, meaning that all that is a progesterone deficiency. So you may not have some of those symptoms that I showed on the slide. And it impacting lab work too much. I mean, could impact, I guess, like your luteinizing hormone, and but it's not to that degree. So I would still, even if you're having symptoms, go to that MRS questionnaire that I showed you guys earlier, you gals, and start looking at that. Because really, as I was sharing with Yen, oftentimes now with hormone therapy, we're treating the symptoms, not the lab numbers. But the labs are there to look at you holistically, to rule out other issues. And then we start treating the symptoms over time. Does that make sense?
Yep. Yep.
I
And then
see one
yeah,
about gabapentin. Can I answer that real quick?
which one?
Isn't gabapentin for seizures? Yes. Yes, it is. It is for seizures, and, healthy, not healthy. A lot of people have perspectives on pharmaceutical drugs, so I don't throw the baby out with the bathwater. Some people are very like, I don't want to do supplements or this or that. And, usually they're not coming to see me if they're like that, but I just wanted to say that that's out there, and don't be surprised if your doctor prescribes that to you. It's used off label for a bunch of other things too, but it can help with vasomotor symptoms.
Mhm.
Okay.
So there's a couple of, if I have a progesterone IUD, how would that mask symptoms? Okay, we read that one. How can I work with you? We have that information. If I can't take hormones due to blood clotting disorder, what options are out there for energy and overall well-being at 45?
Yes. Yeah. Hi, Anna. So, Anna, like a big thing is looking at your detoxification pathways, your something called your mitochondrial health, your mitochondria crank energy, okay, and your circadian rhythm. All right, so they're looking to something called circadian training. That's a really big thing to look into. And then there are going to be different supplements and different phytogens that can support based on what symptoms you're having. But specifically, you talked about energy. You're going to look for things that are supporting your mitochondria. Okay.
Right. How does birth control affect? I take the pill continuously, so don't know if I'm in menopause, 49 years old.
Yep. Yep. So Rosemary's like we were talking about, you're on those hormones already. So yeah, it's very hard to tell. And more than likely, hopefully you don't experience other symptoms, but let's say you are, this is where you could do like a trial off of the medication. You're working with your provider with your doctor to look at other things that may impacting you. Like, is it your mood? Is it your like where are these symptoms? Remember, because each thing has a differential diagnosis. Okay.
Are you able to like kind of wean off of from one like hormone therapy, I would say, because I think birth control and that type is a hormone therapy in
It
itself as
is.
well,
It
right?
is a
And
hormone
so
therapy.
could you work with your physician? And I don't know if they're sophisticated enough to do this, but to wean off of one therapy to going into another therapy so that your symptoms don't fully start.
Sure.
Is that an awareness that like a traditional physician or GYN would
Oh, I don't,
have an idea about?
yeah, I don't
Well,
know. I can't.
sophisticated, right?
Yeah, it doesn't, I mean, it doesn't sound like super sophisticated to me. If someone said, hey, I want to transition to something like, for an example, bioidentical hormone therapy, we would come up with a plan together and then realize that after we make sure that there's no abnormal uterine bleeding, things to like watch out for. They haven't had any issues age 49 up until this point. We can transition, but just do expect that you may have some cycle irregularities, especially because you're doing this at a later stage in life. Well, I don't want to say later stage, I should say later in your reproductive cycle or reproductive life. Yeah.
And then I purposely switched to a female GYN provider who specializes in caring for women in perimenopause and menopause. I was hopeful to discuss hormone therapy. She didn't seem open to pursuing hormone therapy, concerns about weight gain, start migraines with perimenopause. What are some suggestions to help foster discussion with providers for hormone therapy? I think it might be something that will be very helpful.
Yeah, Laura, I mean, that's a beautiful question. And ultimately, they call it the art of medicine for a reason. It is like an art and it's non-prescriptive necessarily for us. And so, as Yen mentioned, and I mentioned at the beginning, we have our different philosophies in treating, and so if she is not someone who's open to pursuing that, but that's something that you really want to pursue, at this point, I'm going to have to say maybe look for a different provider.
Especially if you know that you want to try it because their symptoms are bad, right? And
Yeah.
nothing else has worked, or whatever she's been prescribing or supporting with still doesn't work, then it's time to find a person that can
Yeah.
support with
And
that.
it could be, Laura, like there's some really hardcore, like awesome physicians out there who are going to talk about like ketosis and sunlight and cold plunge and like really optimizing your body. If she's one of those biohacker doctors, like I can kind of, or he or she, no, a female GYN. Okay. Then I can see why, because they're advocating big time for like biooptimization prior to starting hormone issues. Does that make hormone
Yeah, it makes
therapy?
sense. Yeah.
Yeah.
At least for me, like so. What are the risks to HRT, BHRT? Sounds like impact to the liver, anything else? I think it was just more, it's all depends on your pre-existing conditions as well and family history of
Yeah. So like, do you have fatty liver disease? Okay, because that's a really easy screening ultrasound to look at that. Your comprehensive metabolic panel. What do your liver labs look like? Your clotting factors look like. Those are things that are important to uh, take into account. Are you pooping? I know sounds like TMI, but I'm telling you, trash in, trash out. Like basically, are the ways that you excrete things that you don't need, is that optimized and healthy, right? So that's like, the things you have to think about in addition to your liver. If you have cholestasis, meaning like you get like nausea or kind of, GI symptoms, heartburn or stomach pain every time you eat, well, I'm going to tell you right now, I would address that first. Make sense?
Yeah. And any lab specific, because my doctor didn't obviously test my liver, any lab testing for around the liver area, right? And so any specific lab tests, if they do want to insist on therapy and, and we say the liver could be impacted, is there anything just to make sure that your liver is healthy to start off with? Bilirubin or anything like that, or,
And that's going to be in a comprehensive metabolic profile, a CMP that'll be in there. That's a good like baseline screener. And
yeah.
then I would look at something like high sensitivity CRP
Mm.
or C-reactive protein, like look at your inflammatory markers like uric acid, ESR. Those are going to say, is my body inflamed? They're non-specific. Your platelets are also a non-specific indicator of inflammation. Are you anemic? Because that's like why, what's going on with your cycle, or are you having issues with like ferritin and hemoglobin production and things like that? So those are going to be the standard kind of labs that any doctor should be checking on you. Mm-hmm.
I think there's a good one right here, just because we're out of time. So,
Okay.
I just want to make sure that we're being, time sensitive to
Sure.
everyone's time, and
Sure.
then also giving them as much, information as possible. So, what options do I have if I've had breast cancer and my oncologist prefers that I cannot have hormone therapy?
Yeah, that is, Lisa, a very personal conversation to have.
Mhm.
That I don't think that this is the appropriate forum to discuss that in, with like all due respect and love. We really want to get informed what, estrogen sensitive, therapy. There are some oncologists who are actually very pro estrogen and being able to look for that. And so there's a lot more behind like what therapies and treatments you've had. So it might be that you start looking for a second opinion.
Yes, yes. Okay, so I think we'll wrap that up from there. If anybody here wants to speak with Dr. Michelle Cox one-on-one, she's offering a 15-minute discovery call.
Yeah.
I dropped the information and link. I'll drop it again just so you all have it. But please, and then tomorrow I will send everybody an email with her website and her appointment link so that you can book some time with her. It's worth having that 15 minutes because my time with her allowed me to actually go to my doctor and actually request because it gave me a path of what I should be researching that was right for me. And then from there, I went and then I requested from my doctor because I was educated enough to ask for what was right for me. But I'll tell you, before that, I didn't want therapy, and Michelle can say that. And I was just, I don't want that. I don't want that, right? But then I started really digging into it. Some friends recommended some books. I started doing other research, and then I said yes, and then I feel great. And I'm not advocating yes or no either way. That's just my experience I'm expressing. And so tomorrow I will send out an email with her information that you can contact her directly. And then if you want this recording, reach out to her. She has access to send it to whoever wants the recording. I'm not distributing it publicly, but Michelle can share it with you if you reach out to her. Um, and so I want to go ahead and Michelle, do you have anything to add on? And then I'll finish up the remark a little bit.
Just know that this time is amazing. It is a sacred time where you're transitioning into the wise woman, moving from like, creating children to like literally creating your legacy. And it's a time to tune in. So it's a beautiful, beautiful time. And thank you for allowing me to share this information with you today in
Wonderful.
this space.
And so I'll just since we still have some people left, let me share our next webinar in 2 weeks. We'll be providing a free live webinar every 2 weeks, and our next one will be on how to build muscle and wellness without stepping on the scale with Lauren Updike. She's an elite athlete, athletic coach, and chief wellness officer for University of Washington, former chief wellness officer for Duke University. And I'm looking forward for all of you to be there as well. I think this is a great topic in building strength and bone density and muscle around this time of our life. And so keep an eye out for that for that webinar link and any information on that webinar link I'll be sending out starting next week. All right. I appreciate everyone. Thank you so much. I hope this was helpful. And I think, reach out to Michelle if you have any questions. All right.
All right.
Take care,
Cheers. Thank
everyone.
you. Bye.
Bye, everyone.